We've got a stack of sources today that take us right to the front line of the body's most crucial control systems. I'm talking about the airways and the digestive tract.
These are systems built on, well, incredibly precise chemical messages and muscle control.
And when they fail, life gets miserable and fast. Our mission in this deep dive is to unpack the physiology of what's going wrong and, I think, more importantly, the exact logic of the fix.
That's the key. I mean, we aren't just here to list drugs. We are connecting the dots. For every medication we talk about, the real question is, what precise physiological problem is this compound actually correcting?
Okay, let's unpack this. And maybe we should start with the simplest, most vital mechanism, just breathing. When we talk about conditions like asthma, the core problem is just that air can't move properly.
Right, oxygen exchange is impaired. It's the definition of an obstruction. And the sources tell us it happens in, well, one of three main ways. The smooth muscles around the airway can clamp down like a tight ring, or the tissues swell up from chronic inflammation, or, the tubes just get clogged with thick mucus.
But the result is always the same: less air in and less carbon dioxide out.
Exactly. And the why behind it is often a hyper-responsive airway. It's just overreacting to triggers, allergens, smoke, even just cold air.
And that's when you hear that classic wheezing sound.
Which is why diagnostic tools like spirometry are so critical. They don't just say, yep, there's a problem. They help categorize it. Is the main issue inflammation, or is the immediate danger that muscle tightening?
And that distinction leads you straight to the treatment choice.
It dictates everything. Do you need a preventative controller, or do you need an immediate rescue?
Let's look at the long game first. The controller drug. Something like beclomethasone, a corticosteroid. This isn't for the emergency, right?
No, this is the philosophical fix. The core long-term problem in asthma is inflammation. Beclomethazone's whole job is to address that root cause.
So how does it do that?
It's an anti-inflammatory powerhouse. It literally goes into the airway cells and basically turns down the volume on the genes that produce inflammatory chemicals, cytokines.
So less inflammation means less swelling, less mucus?
And over time, the airways just become far less twitchy and hyper-responsive.
Okay, so it's a preventative measure, changing the whole cellular environment. But the sources flag a really serious multi-part safety alert here.
They do.
Yeah.
And it speaks directly to how a steroid works. First, because it's a local immunosuppressant, you absolutely have to rinse your mouth after using the inhaler.
To prevent oral thrush, right?
To prevent oral thrush or candidiasis.
Yeah.
But the deeper alert is about what happens if you stop it suddenly after long-term use.
Adrenal suppression. For those of us listening who aren't clinicians, what does that actually feel like and why does it happen?
This is a huge teaching point. So your adrenal glands, they naturally produce cortisol, which is your body's own life-sustaining steroid. When you give an external steroid like beclomethasone for a long time, your body's feedback loop says, hey, we have enough. And the adrenals get, well, lazy. They stop producing their own cortisol.
So if you suddenly stop the inhaler,
You're left with no cortisol support at all, and that can cause a severe life-threatening crisis. We're talking profound weakness, low blood pressure, even shock. It just shows how fundamentally the drug is altering a key hormonal process.
wow, that really puts the controller strategy in perspective. So now let's contrast that with the fixer, the immediate rescue inhaler, like albuterol.
Right. If the controller calms the long-burning fire, albuterol knocks down the locked door. This is for when the immediate danger is that muscle tightening, that feeling of a vice grip around your airways.
And its mechanism is totally different.
Completely. It stimulates specific receptors called beta-2 receptors, which are all over the smooth muscle in the airway, and that causes rapid, life-saving relaxation.
Now, when we talk about beta-2 receptors, is that related to the same system that makes my heart race when I'm, nervous? How selective is this drug, really?
That's a great question because it explains the side effects perfectly. While albuterol is mostly selective for beta-2, those receptors also exist in the heart and skeletal muscles.
Ah, so that's why it's not a perfect fix.
It's why common side effects are things like jitteriness, tremor, and palpitations. You're accidentally stimulating those other tissues too.
Here's where it gets really interesting. The sources point out that how often you use it becomes a diagnostic tool in itself. There's a huge drug alert about this.
A massive red flag. Needing your rescue inhaler more than twice a week tells you one thing. Your underlying inflammation isn't controlled. Your controller isn't doing its job.
And it gets worse, right?
It does. Chronic overuse can actually cause those beta-2 receptors to become desensitized. They downregulate. So the rescue inhaler becomes less effective right when you desperately need it to work. You're literally making the acute problem worse by ignoring the chronic one.
We can apply that same logic of precise receptor targeting to the upper airway too, right? Like with nasal congestion. The problem isn't just mucus, it's swollen blood vessels.
Precisely.
Yeah.
Inflammation makes the blood vessels in your nasal passages dilate and leak, and that's what narrows the airway. Phenylephrine, a decongestant, targets what are called alpha-1 receptors.
And what do they do?
When you activate them, they cause vasoconstriction. They shrink those swollen vessels, which physically opens up the passage.
So the fix is just shrinking the supply lines. But based on that mechanism, tightening blood vessels, the safety alert has to be a big deal for anyone with heart issues.
Oh, absolutely. Because alpha-1 receptors help regulate blood pressure all over your body, you have to avoid phenylephrine in anyone with uncontrolled high blood pressure or coronary artery disease. It's just too risky.
And there's another alert for everyone else.
Yes, strictly short-term use only. If you use it for too long, that prolonged vasoconstriction leads to a severe rebound congestion when the drug wears off. You get trapped in a cycle of dependence just to breathe.
Okay, that's a perfect illustration of targeting muscles and vessels. Now let's pivot from air management to the other major tube system, the gut.
We're still dealing with issues of precise chemical and muscular control. The logic of the fix in the GI tract usually involves tackling one of three main failures: too much acid, a breakdown of mucosal protection, or impaired motility.
Let's start with the acid problem. The sources lay out a kind of hierarchy of drugs. Starting at the lower end, we've got famotidine, the H2 receptor antagonist.
This is a really elegant approach. Histamine, specifically H2, is one of the main signals telling the stomach to start pumping acid. Famotidine just blocks that specific receptor.
So it reduces the stimulation for acid. It doesn't shut the whole factory down.
Exactly. It lets the gut heal while still preserving some stomach acid, which we need for digestion and, fighting off infection.
It's more like modulation than destruction. But the sources flagged a safety concern, particularly for older adults.
Yes, because famotidine can cross into the central nervous system, there's a risk of confusion and other CNS effects, especially in older adults or anyone with kidney problems, because if you can't clear the drug efficiently, it builds up.
But sometimes modulation just isn't enough, and you have to go for the total shutdown. That's where omeprazole comes in, the proton pump inhibitor, or PPI.
This is the big gun. You need it for severe chronic conditions where the H2 blockers just aren't cutting it. The whole philosophy shifts from reduce stimulation to eliminate function.
So how does it do that?
Omeprazole irreversibly blocks the proton pump itself. That's the literal molecular machine that spits acid into the stomach. It doesn't matter what signals are there. Acid cannot be released. It creates this powerful low-acid environment that allows serious damage to heal.
So if famotidine intercepts the instruction memo, omeprazole just smashes the machinery in the factory.
That's a good way to put it. But the costs can be significant. The sources listed a serious array of possible issues with long-term use, which is common since it's so effective and often over-the-counter.
What are we talking about here?
Well, that unnaturally low-acid environment is great for healing ulcers, but stomach acid is critical for breaking down nutrients. So long-term use carries a risk of hypomagnesemia, B12 deficiency, and even increased bone fractures.
Because you can't absorb the minerals properly.
Exactly. And there's also an increased risk of GI infections like C. difficile.
The sources called these effects silent. Why silent?
Because they don't produce immediate symptoms. You don't feel your B12 levels dropping until maybe years later neurological issues start. You don't know your bone density is eroding until you get a fracture. It's a slow burn.
Okay, so what if the problem isn't the acid, but the fact that an ulcer is already there and just needs to be protected?
And you don't want to reduce acid, you want to protect the wound. That's the job of sucralfate. It's a mucosal protectant.
And what's fascinating is it needs an acidic environment to even work, right?
It does. The acid activates it. Once it's activated, it binds to the proteins at the ulcer site and forms this sticky physical barrier, like a therapeutic bandage against the acid.
The administration alert on this one seems critical because of that sticky nature.
It's a physical binder. You have to take it on an empty stomach, and really importantly, you have to space it out from other medications, sometimes by hours.
Because it'll just bind to them and stop them from being absorbed.
It will render them completely ineffective.
Okay, let's tackle the other huge GI issue, constipation. The sources really stress that you have to know the why. Is the stool too dry, not enough bulk? Or is the bowel just lazy?
And our 4 classes of laxatives target those 4 specific failures. The logic is just beautiful in its simplicity. You match the fix to the mechanical problem.
Okay, first up, psyllium. the bulk-forming agent. This is usually the first line of defense.
Right, because it fixes a lack of bulk. Psyllium is fiber, it absorbs water, forms a soft, bulky stool, and that bulk physically stretches the colon, which is the natural, healthy way to trigger peristalsis. It's retraining the bowel.
But the safety alert is dramatic. You must take it with a full glass of water.
This is non-negotiable. If you don't, that fiber will absorb whatever little fluid is around and turn into a solid, concrete-like mass in your esophagus or gut. You can create a life-threatening obstruction.
Wow. It turns the fix into the crisis. Okay, next we have Docusate, the stool softener. This is for hard stool.
Correct. It's a surfactant. It reduces surface tension to let water and fat penetrate the existing hard stool to soften it. You use this to prevent straining, which is vital for post-op patients or anyone with a heart condition.
And what if the bowel is just genuinely lazy and we need to force the issue?
That's when you turn to a stimulant, like Bisacodil. This works by directly stimulating the nerve endings in the colon wall, forcing a contraction.
But the safety warning here is huge.
It is. Use it only for the short term. If you use it long term, the bowel muscle loses its own tone and function. It becomes dependent on that chemical kick to do its job. A really vicious cycle.
And finally, the osmotic fix, like magnesium hydroxide.
Osmotic laxatives work by drawing water into the intestines through osmosis, which softens the stool quickly. They're effective, but you have to remember the systemic connection.
The magnesium.
The magnesium. It's cleared by the kidneys. If a patient has renal impairment, their kidneys can't clear that excess magnesium, and you can get hypermagnesemia, which causes severe lethargy, depressed reflexes. It's dangerous.
If we connect this to the bigger picture, this level of precision continues when we look at antiemetics. So stopping nausea. This isn't just one failure, it's a signal problem.
That's a great way to put it. The nausea signal can come from the GI tract, from the vestibular system in your ear, or from toxins in your bloodstream. They all funnel through a place in the brain called the chemoreceptor trigger zone, or CTZ.
And each signal uses a different neurotransmitter.
Exactly.
Yeah.
So our drugs work by precisely blocking those specific pathways.
Let's start with the one most people know from post-chemo or post-op care, ondansetron.
Ondansetron is a serotonin, or 5-HT antagonist. When your gut is irritated, say from chemo, it releases a flood of serotonin that tells your brain to induce vomiting. Ondansetron just blocks that serotonin signal before it can get to the vomiting center.
And the safety warning.
It's cardiac. It carries a risk of something called QT prolongation, which can lead to dangerous cardiac dysrhythmias, especially at higher doses. It can mess with the heart's electrical rhythm.
Then there's a more specialized drug, aprepitant, that targets delayed nausea.
Right, aprepitant targets substance P. It's so important because it's one of the few things that can prevent the delayed nausea from chemotherapy. You have the acute phase, which ondansetron can block, and then a delayed phase that can hit days later. Aprepitant is critical for that delayed signal.
Now, if the nausea is from medications or toxins, we turn to dopamine antagonists like prochlorperazine.
Yes, prochlorperazine blocks dopamine in the CTZ, and it's a very powerful central block. The problem is dopamine is absolutely integral to motor control pathways elsewhere in the brain.
Which is why it carries that high risk of extrapyramidal symptoms or EPS.
Exactly.
That sounds alarming. If I'm listening right now, what's the one thing I should watch for if I or a loved one takes this? What does an abnormal muscle movement actually look like?
You're looking for involuntary muscle movements, stiffness, or this intense restlessness called akathisia. It can be facial grimacing, tongue movements, uncontrollable spasms in the neck or back. These signs have to be reported immediately, because EPS can be severe if it's not addressed.
And finally, we sometimes see a steroid, dexamethasone, added to the mix.
That's for its anti-inflammatory effects. If the nausea is being triggered by underlying inflammation, like cerebral edema, the steroid calms that component down. It's not blocking a signal, it's reducing the physical irritant.
So what does this all mean?
It means that a deep dive into your medicine cabinet reveals this world of, well, astonishing precision. Every mechanism, from turning down inflammatory genes with a steroid, to shrinking vessels with a decongestant, to locking down the acid pump with a PPI, it's a surgical choice based on a specific identified failure.
We've really seen that clear division. The controller versus the rescue, the softener versus the stimulant, and, blocking serotonin versus blocking dopamine for nausea.
And what we've learned is that understanding the mechanism is inseparable from understanding the risk. The most powerful drugs are often the ones that carry the highest cost, whether it's dependence from a stimulant laxative, an adrenal crisis from a steroid, or those neurological side effects, EPS, from a dopamine antagonist.
So the choice is always about balancing that risk against the immediate need.
And that leads us to the final provocative thought. We talked about how effective omeprazole and other PPIs are at shutting down acid. And the sources were crystal clear about the silent long-term risks. Hypomagnesemia, B12 deficiency, bone fractures, all because stomach acid is necessary.
Right.
Given how easily you can get these powerful acid suppressors over the counter, the question to leave you with is this. What essential evolutionary function of the human body are we disrupting, perhaps too casually, with the chronic use of these medications? That's the question to consider as you